Canada has a new distinction. Our country has been crowned the second largest Ozempic user in the world. Most of us know about this drug for weight loss, courtesy celebrity promotions like Oprah's.
The new weight loss drugs, everybody's talking about Ozempic.
But the reality is that Ozempic, or semaglutide, was first developed for type 2 diabetes, a serious disease that can cause blindness, kidney failure, amputations, and heart attacks. And that's exactly why 53-year-old Luc Rossignol is on the weekly injection to keep him out of harm's way.
It keeps our sugar levels down so we don't get in danger of losing eyesight, losing an arm or a hand or a leg.
His work insurance covers the sum $200 to $300 a month. Other Canadians pay for it out of pocket. This podcast is about the growing cost of this medication to our public health system, with many provinces and territories now paying for Ozempic for seniors, those with disabilities, and other issues. A new report by the Canadian Institute for Health Information shows our health system has gone from spending about $13 million a year for Ozempic to now over $800 million a year, a nearly 6,000% increase in a handful of years. And this is now the fastest growing drug expense on the public purse. Sticker shock for some, totally worth it, says diabetes specialist David Lau from the University of Calgary.
Over the short term, yes, we may see a dramatic increase in the cost to the health system, but don't forget, there's still a dramatic increase in the prevalence of obesity and type 2 diabetes.
I'm Avis Favaro, and welcome to the Canadian Institute for Health Information podcast. A note, the opinions expressed here don't necessarily reflect those of CIHI, but this is an open discussion on the eye-watering public health bill for Ozempic. And joining us now from Calgary, Dr. David Lau. Welcome. Thanks for coming.
Well, thanks for having me, Avis.
Yeah, our paths have crossed a number of times over the decades. And I just wonder, could you have ever imagined that we would be sitting here talking about this entirely new way of treating diabetes decades ago?
Yeah, we now have game-changing medications available that, honestly, as a diabetes expert, I would not have imagined 10 years ago that we'll be in this space.
Now, this podcast is about Ozempic, and we're talking about the Ozempic that's covered by the health system in Canada. It is being used a lot. How often do you prescribe it for diabetes, type 2 diabetes?
The GLP-1 class of medication was first available, I would say, about 10 years ago, and it was rarely used. Because it was an injectable medication, and most of the time you have to give daily injections. But until the availability of semaglutide, which is a weekly injectable medication, and this is really a game-changing class of medications that not only help people to improve their blood sugars, but also to help them to lose weight. And as you're well aware, type 2 diabetes is often associated with obesity, which is the major driver for a condition called insulin resistance, the precursor for type 2 diabetes. So you're dealing with a drug that has, if you will, a dual benefit of not just lowering the blood sugar, but also reducing body weight, reducing body fat, and improving the overall health of individuals.
Conservative estimates suggest there are over 1 million Canadians now being prescribed Ozempic for type 2 diabetes.
They advised us on our eating habits and trying to exercise more and all that. When that didn't work, well, we started with medication, and the side effects are cruel.
Like 53-year-old Luc Rossignol, a business owner in Edmundston, New Brunswick. No matter what he did, eat better, exercise, he couldn't bring down his blood sugar, in particular one marker called A1C. So he joined Ozempic Nation with encouraging results. What were you most afraid of in regards to having type 2 diabetes? You know it's a serious disease.
Oh, it is. Yeah. Oh, yeah. And me, every 3 months, I see my doctor. I own 2 trucking companies. I have a class 1. So I need to pass test every year for my eyes, the sugar, and all that stuff. I got to pass a physical and everything every year. And I'm very meticulous with this. I don't miss the beat on this.
I have to say, Luke, you're not the typical man. I know so many men that don't want to go to the doctor. They don't want to.
Really? No. Me, I'm proactive. I mean, I want to live long. My father passed away at 48, and it's very important for me to watch my health. And I'm a grand uncle now, and those kids are awesome. And I mean, I want to see them grow, and I want to be around them. And so you have to do this if you want to live long, right?
So when the doctor said, let's try Ozempic for your type 2 diabetes, and you started on it, so it's an injection once a week for you, right?
Yeah. Well, actually, I'm the one that talked to him about it because my A1C, I've been fighting to get that down below 7 since I'm diabetic.
And for people who don't know what A1C is, what does that measure tell you, the A1C?
The A1C is the average blood sugar for 3 months. And in the medical field, they want that below 7. And I was always above 7.2. And I went up to 7.8, 8.1 at one point. And the doctor was like, Luke, you have to do something. So, yeah, okay. So I would change some stuff in my lifestyle and bring it down a little bit. But then it came back. So then when we changed to Ozempic, I've been on Ozempic now probably a year and a half, 2 years. So when the results started coming in, you saw a drastic change in my A1C. It went down from like, let's say 7.5 at the time, went down to like 6.9. I was like, whoa, I'm under 7. So right now, my last results that I did were I was at 6.4, and I'm just stable there, and it's perfect. And doctor's like, I don't know what you're doing. Don't change the recipe. This is perfect. The other thing that the Ozempic works on your stomach too, it'll slow down the digestion so you feel full longer, so you don't have tendency to eat here and eat there all the time, you know.
You notice your appetite is down?
Oh, yeah. Oh, yeah. When I was younger, I could eat like 2 hamburgers and a large fry, and that would all go in and no problem. And then a piece of pie at the end. But now that doesn't happen. You know, I'll eat a hamburger and I won't even finish a fries. So,
I mean, so have you lost weight while you've been on Ozempic too?
I don't go up and down anymore. It's like I get on the scale and it's too spot on and doesn't change. Yeah.
You know, the doctors go, we will see a reduction in amputations and kidney failure and blindness down the road. You believe that?
Well, yes, I believe it because I have the results. Personally, I have the results. My A1C is below 7 and it's sticking there. But you still have to have a will. That's just putting a Band-Aid. I mean, you have to have, you have to make life changes. You have no choice.
So you are pretty confident this drug is going to help you live longer and see your grandnieces and nephews.
Oh, yeah, for sure. But, and then you have all those people saying, oh, you should stop that. It's not good for you. It's going to hurt you.
And what do you think when people say that? They don't understand.
First of all, they don't live with the disease and they don't know what it is and how hard it is, you know, because it can be hard to manage, you know, if you don't have medication.
So, Dr. Lau, have you seen patients where they couldn't do it and the drug transformed their life?
Oh, absolutely. I think that's the majority of the situation. Many of them now can come to my clinic and say, Doc, you know, I'm absolutely amazed by the fact that I no longer think about, you know, constantly about food, about what to eat next. Because many a time they don't realize the food noise is so overwhelming that really they can't do it on their own. And the other thing to remember is obesity is not just a lack of willpower. When we gain weight or gain body fat, our brain is rewired in such a way that we become more and more obsessed about food. So the Ozempic class or GLP-1 class of medication really helps to not only reduce the food noise, but it also changes the person's food preferences. So they're now eating less fatty foods, they're drinking less sugar-sweetened beverages, so they're saving in the grocery bills. So there actually are studies to demonstrate that people on GLP-1 class of medications actually see a 15% reduction in the grocery bills. And as you may be aware, the food industry is very concerned that people are eating less ultra-processed foods as a result of taking the GLP-1 class of medication.
They have to come up with different kinds of foods.
Yeah, and different snacks. So this is the Ozempic industry that we refer to. So that really has been the major game changer.
I bet it has. So the newest data from CIHI, which tracks public health spending within the health system of drugs, has found that overall drug spending has gone up to $20.1 billion with a B. The largest contributor to the public drug program spending growth was Ozempic, which has gone up from $660 million in 2023 to $807 million in 2024. That's 8.5% of total growth. That's not even 2025. That's 2024. When you hear those numbers, do you not want to do a quick, oh my gosh? What's your reaction?
You know, as a diabetologist, I'm delighted to see a much broader use of Ozempic or semaglutide, because this is the class of medication that really truly benefits people with type 2 diabetes. So I understand the cost, but you also have to look at the downstream benefits of the cost savings in terms of the improvement in health gains. Diabetes can affect productivity in terms of absenteeism from work, and those have to be factored in. So even though, yes, we're talking about a dramatic rise to the healthcare system in terms of the cost of the medication, but we should also look at the gain in productivity and the health gains to the individuals. So in the end, you're talking about perhaps 10 years down the road, a much lower cost to the healthcare system because of the benefits.
Okay, let's talk about those benefits, because what we want is for Canadians to understand why is so much of our tax dollars being spent on one drug. Are there more people with type 2 diabetes that can't be controlled with the other standards of care?
Yes. In Canada, we're talking about, on average, 1 in 10 adults with type 2 diabetes. And the numbers go up with age. So if you're dealing with the seniors over 65 years of age, you're talking about literally 1 in 5 individuals with type 2 diabetes. That's 20% of the senior population. You're talking about a huge number. You have to look at what is the cost of diabetes to the healthcare system.
Yes, and I saw one estimate that it's $18 billion in direct healthcare costs, amputations, heart disease, vision loss, and the majority of it is coming from type 2 diabetes.
Absolutely. So if you're looking at even a 20% increase in the cost to the healthcare system of game-changing medications. So this is yes, it's costing the healthcare system. But to me, I'm absolutely delighted that more and more patients are now accepting the use of GLP-1 class of medication because of the potential benefit, reducing the risk for cardiovascular disease. And eventually, you have to factor that in terms of the premature death as a result of type 2 diabetes and the delaying of that.
Are we seeing those benefits yet in Canada in the health system?
Well, unfortunately, when you're looking at clinical trial data, there's always a lag, partly because collecting data requires time. Now, in the study that I referred to using semaglutide, the benefit was seen within 2 to 3 years. So within 2 to 3 years, you should be able to see studies coming out to demonstrate the downstream benefits of drugs like Ozempic, how that would reduce the prevalence of kidney failure in people with type 2 diabetes, along with all the other benefits that you're referring to, amputation, blindness. All of these are really serious complications associated with high blood sugars.
Because this increase, is not trivial.
But unfortunately, we have not seen a decrease in the prevalence of type 2 diabetes. Diabetes is on the rise. And that translates into decreasing the prevalence of obesity, because obesity drives up the cost of, the prevalence of type 2 diabetes.
And now the WHO has said, well, this should probably become first line for obesity. How close am I on that?
The Canadians actually are very good at promoting clinical practice guidelines, and we're at the forefront when it comes to obesity management. We published the 2020 clinical practice guidelines on the management of obesity, and there we emphasize that instead of blaming our patients for the lack of success, the lack of willpower, we really have to look at obesity as a chronic relapsing disease, in which case healthy behavior intervention is absolutely essential. It's a cornerstone management. But if that fails, then we need to consider medical therapy as part of the management spectrum. Don't forget, Ozempic will be going off patent, which means that the generic drugs of semaglutide will become available this year. That will help to drive the cost down by at least 20, if not more % in terms of the cost. So the cost to the healthcare system will see a reduction, and hopefully more and more people will go on this class of medication.
But Dr. Lau, I understand that some provinces still don't really cover Ozempic for diabetes. They want people to use other medications. And so the numbers that we're getting from CIHI on its use within the public health system might actually be an underestimation. Is that right?
Yes. I can cite evidence from British Columbia as an example. British Columbia is the province where drug approval is much slower because of the concerns of the cost. They still recommend the older generations of blood sugar lowering medications, even though we now, the clinical practice guidelines no longer recommend those classes of medication because...
This is like metformin.
Not so much metformin, but the sulfonylurea class of medication. We do know the sulfonylurea medications can cause low blood sugars, increase body weight, worsening the natural course of type 2 diabetes. So even metformin, which the clinical practice guidelines recommend as a first-line drug, many scholarly diabetes organizations have now abandoned metformin as the go-to medication or first-line therapy because of the robust clinical benefit with the GLP-1 class of medication. So the future clinical practice guidelines will not only recommend the GLP-1 class of medication literally as a first-line drug ahead of metformin in some individuals.
So more people, more Canadians will be on these drugs for diabetes and weight loss pre-diabetes.
Yes, absolutely. I should say that we still don't have official approval of this class of medication for diabetes prevention, but we do know the benefit downstream because when it comes to preventing or delaying or achieving diabetes remission, you need at least 10 to 15 or if not greater % body weight loss to see the benefits. And I'm not advocating that every person with type 2 diabetes should go on medications. But, I think in all likelihood, the GLP-1 class of medication will become even more prominent as part of the diabetes management.
If I was a politician managing the provincial budgets across the country, this would make me slightly worried, because how do we manage all of this? Can you understand that?
I totally get it. That's why I think we should also remind Canadians that if we adopt healthier eating habits, decreasing the consumption of ultra-processed foods, we can decrease the prevalence of type 2 diabetes. And that, to me, is the ultimate cost savings.
So, Luke, when you hear that Canada's spending so much on this drug for people with type 2 diabetes, what do you want Canadians to know about this drug and how it affects the lives of people with type 2 diabetes?
Well, it keeps us, I think, out of harm's way in the sense that it keeps our sugar levels down, so we don't get in danger of losing eyesight, losing an arm or a hand or a leg, or. And I think if we didn't have that, well, people would get more and more sick on diabetes. So I think it's a good medication.
So, Dr. Lau,
If we were to be having this conversation in 10 years, what would you hope the data would show to justify all the spending?
Well, I hope that fewer Canadians will have type 2 diabetes. I hope that fewer Canadians will have obesity. I'm a perennial optimist, so I'm hoping that over the short term, we may see a blip in terms of the cost to the healthcare system, but over the long term, there will be benefit that we see overall.
I hope you're right, because it seems more than just the drug. It's about how a universal health system actually decides what it's willing to pay for, with the idea that there will be benefits that they might not see for a decade or more.
Oh, absolutely. Not just talking about dollars and cents, but the improvement in terms of the health years, free of complications of diabetes, the grandparents who can actually be dancing with their grandchildren. And those are the things that I'm hoping that would become a reality. So we still have a lot of work to do. But don't forget, we're living in an endemic era of diabetes and obesity. So I think the cost is relatively trivial over time.
All right. Listen, Dr. Lau, thank you so much for your time. I hope this gives people a better understanding about why the drug costs are going up.
It's my pleasure. Thank you very much for having me to join you on the podcast.
is there a downside to Ozempic for type 2 diabetes? Sure is. Some people suffer side effects including nausea, vomiting, and in rare cases, vision problems. Some don't even continue on the medication. Meanwhile, CIHI is also working on collecting better data on those benefits that we talked about with Dr. Lau to give Canadians a clearer picture of the costs versus those hoped for long-term health benefits. You can find out much more about drug spending in the health system at CIHI.ca. I'm Avis Favaro. Thank you for listening, and talk to you next time.